All right, guys, welcome to chapter 14. This is when this class starts to get fun. We start to work on different body parts and learn more about specific exercise prescription based on body part, region, and function. So where we're going to start first is the spine, one of my favorite areas. And we're going to start first with the structure and function. A lot of this is anatomy, and I surely hope that this is a review. There are 33 vertebrae in the spine with respective discs. You should know this. 7 cervical, 12 thoracic, 5 lumbar. You have fused sacrum and coccygeal bones. All right, more on the anatomy. So you have your anterior and posterior pillar of the spine. The anterior pillar consists of the vertebral body, the vertebral body and the discs, and its main function is for weight bearing. With patients who have compression fractures, typically they will get a compression fracture of their spine in their vertebral body in this anterior pillar area. The posterior pillar consists of the vertebral arch and the articular processes and the facet joints. The purpose of this area is to have protection for the spinal cord that goes down and to allow attachments of muscular and ligamentous structures. Additionally, the shape of the posterior pillar allows for some stability, which we will talk about here soon. It provides inert structural stability to the spine. Now we need to define motions of the spine. And when we're defining these, I want you to think of what's going on at the spinous movement or at each spine level. So with flexion and extension, which is listed here in A, when you flex the spine, you will be compressing the anterior part of the disc and you will be relieving some pressure on the posterior part of the disc. Additionally, the intervertebral foramen will have increased space there. Conversely, the opposite will happen with extension. So with extension, you will end up with a compression of the posterior part of the disc and in some distraction of the anterior part of the disc. You will also have a decrease in the intervertebral foramen. For B, this is side bending. So with side bending, you're going to have compression on the side that you're bending to. So this individual is doing a right side bend. The right side of the disc will be compressed. The left side has slight distraction. If you think posteriorly, the foramen and all the posterior pillar structures on the right will have less space between them. They will be compressed while there will be some opening on the opposite side. For rotation, you will have more of a, I wouldn't call it a shear, but more of a translational or rotational force on that disc. And depending on the structure in the posterior pillar will depend on what gets approximated and what structures get separated in the back. Anterior and posterior shear. Think of this as when you are having a forward movement that is then stopped. The lower disc will, or the lower vertebrae will stop, and the one above it may continue forward unless there is a force keeping it from moving forward. And here you will have some translational movement in that disc. You also will have some translational movement of the posterior pillar structures until either there is a bony block or a ligamentous block stopping it. Lateral shear is very similar to that. So this is different than side bending. You're not bending the structures one on top of the other. It is a true side-to-side movement, and you will get some translation of that disc laterally, just like this one had forward translation. This is lateral. And then compression and distraction. With compression, the disc material will be, there will be increased force circumferentially throughout the entire disc, and with distraction, you will have less force on that disc. Same with all the posterior pillar structures. So why is this important? I want you to start thinking of the exercises that you may prescribe and how they may affect what is going on segmentally in that spine. We're going to talk about within these next few days times where we need to create more space in the intervertebral column, or we may need to have a full distraction. You need to understand what movements will create more space or less space, or a distraction or a compression, so that you understand with your exercise prescription what you're doing to that spine and what you're doing either to improve or maybe to harm this patient. All right, arthrokinematics of the spine. So it would be nice if every spinal segment had the same arthrokinematics, but they don't. So we'll get into greater detail in musculoskeletal, but for now I want you to understand some of the basic arthrokinematics of the spine. So at the atlanto-occipital joint, realize that the occiput is a convex facet, and the and I always say the OA, so I'm having to say actually the words out. The occiput is convex and the facets are concave. So when you nod your head into extension, the occiput is moving anteriorly, and when you nod your head into flexion, it is moving posteriorly, and this is described here or pictured here. So with extension, that occiput is actually moving forward, and with flexion, that occiput is moving posteriorly. For the AA joint, the atlantoaxial joint, this joint is primarily rotation. It doesn't fit into the typical joint that we think of. So it does some rotation and a little dip at the end of each rotation. When you are rotating at the AA joint, the side that is one side that is moving forward behaves like it's flexing. The other side that is moving backwards behaves like it is extending. So it is a more complex joint. Now in the cervical spine, the facet joints are angled at 45 degrees from the horizontal plane. So if you put your hands forward with your palms facing forward and up to the ceiling, and then angle your fingers down to at about a 45-degree angle, that is how the facet joints line up in the cervical spine. So with extension, your cervical spine facet of the, let's say, C6 will slide backwards onto C7, and with flexion it will slide forward. In the thoracic spine, those facets begin to move from a more frontal plane orientation to a sagittal plane orientation. And in the thoracic spine, the majority of the movement throughout the vertebral bodies, or the vertebrae, occur in rotation. And then in the lumbar spine, those facets transition from that sagittal plane back to a more frontal plane orientation. And in the lumbar spine, when you flex laterally, rotation tends to occur in the same side. So if you have some right rotation, you also have right side bending. Now, there is some variability though. So if you are flexed, there may be rotation and side bending to the opposite side. The arthrokinematics of the spine can be very difficult to grasp, and again, this is something we're going to get into much more in the musculoskeletal content next year. But understanding the anatomy of the spine is the important part for this class. Now, one thing I do want to add to the cervical spine is that they also have these joints of Luschka. These are bony projections that provide some stability to the spine and also to help reinforce the posterior wall of this disc to help prevent any posterior translation of that disc back into the vertebral column or the vertebral canal. All right, the structure of the intervertebral discs. The intervertebral discs are made up of the annulus fibrosus, which is the outer ring, the nucleus pulposus, which is the inner ring, and cartilaginous end plates, which are on the top and bottom, and they or what joins them to the bone. So the annulus fibrosus is made up of dense layers of type 1 collagen fibers. They're angled at about 60 to 65 degrees from the axis of the spine, and I have a better picture of that here. So one sheet will be angled in this, say towards the left. The next sheet will be angled to the right, and then to the left and to the right. So you have different layers of these type 1 fibers that will help support the nucleus pulposus. The orientation of these fibers are such that regardless of the direction that the disc is being moved, whether it's being rotated, distracted, or bent one way or the other, it'll have tensile strength throughout. The nucleus pulposus is a gelatinous mass that has type 2 collagen fibers that are merged with the annulus fibrosus at their inner layer. It is located in the central aspect of the disc. In the lumbar spine, it is slightly more posterior than in the rest of the spine. It has a lot of proteoglycans, which have a high affinity for water. So this helps have a good bit of fluid throughout the nucleus. This high level of fluid helps to distribute pressure evenly through the disc during compressive loads. Because the proteoglycans are present, water will be imbibed or be brought into the disc with some distraction and can be squeezed out during compressive loads. Cartilaginous end plates cover the superior and inferior aspect of the nucleus where they meet the vertebral bodies. And these end plates are responsible for containing the nucleus from migrating superiorly and inferiorly. Right on to the posterior pillar area. So the intervertebral foramen, right here and right here. Realize that your nerves, and you should know this from anatomy, that the nerves, you have blood vessels that can exit through there. With extension, so this is extension of the spine, that foramen is going to be smaller, and with flexion, it's going to be greater. Also note that there is compression on the posterior aspect of the disc with extension, and there's compression on the anterior aspect of the disc with flexion. All right, the curves of the spine, this should be a super review because I know you've had this multiple times, but you have lordotic curve, kyphotic curve, and lordotic curve going throughout the spine. Lateral curves are not typically present. If they are, they should be noted, but we expect the spine to not have curves laterally, but to have curves anteriorly and posteriorly. And going back to our postural assessment from tests and measures, a plumb line should be anterior to the lateral malleolus of the ankle, just anterior to the axis of the knee. It should go through the greater trochanter. It should be through the bodies of both the cervical and the lumbar vertebrae. It should go through the shoulder joint, and it should go just anterior to the atlanto-occipital joint. So think about in biomechanics terms. Let's use the knee for example. If that plumb line is just anterior to the axis of the knee, what is the vector on that knee trying to, what are the forces of the knee trying to do at the knee? Is it trying to flex or extend the knee? So think back to biomechanics. You have a vector that's anterior to the joint of the knee. And if you're thinking it should be moving it posteriorly, you are correct. So in normal anatomy, or not anatomy, I'm sorry, in normal postural alignment, and with somebody with a normal anatomy, if a plumb line is moving just anterior to the axis of the knee, it is trying to extend that knee. So if it is going through the bodies of the cervical and lumbar vertebrae, there shouldn't be a lot of muscle use to maintain good posture. So think of this individual, okay? If they cannot get their hips fully extended or their knees fully extended, they're going to have to use their muscles a lot more. This gentleman's axis is posterior to his knee, so it is putting a flexion moment on that knee, and he is having to use his quads a lot to stand up. It is anterior to his hip, so it's also putting a flexion moment on his hip. So it is pushing his hip posteriorly, so it's actually flexing his hip, which is causing him to use a lot more glutes. All right, and so you can go through the entire body system to think of what is having to work more because of poor postural alignment. All right, so let's talk about stability of the spine. There are three main systems that help with stability of the spine. These are inert structures, active structures, and neural control. So what are your inert structures? These are things that you don't move. Passive structures like bones and ligaments. It could be your disc. Anything that is there just for the protection of movement, but you don't have voluntary control of moving it. Active structures are things that are active, such as your muscles. And neurocontrol is that motor control, that ability to either have feed forward or feedback, or to control the movement that you want. All of these systems are interrelated. And it's similar to balance. We talked about if you have one balance system that's out, you still can have good balance. With stability, you can have one system that's not working well, but if you do, the others must be able to provide the support you need. When you have spinal instability, there has to be a combination that all three systems are not working properly. So you can have inert tissue damage that's led to hypermobility in the spine. You can have insufficient muscular strength so that you cannot control the movement, or have poor neuromuscular control or poor understanding of what is needed to control that movement. So these inert structures, what are they? One, they are the bones. We have, your bony system is set up so that there is a limit on mobility. But things such as the anterior and posterior longitudinal ligament, they limit how far both the vertebrae can move and how far the disc can move. The intertransverse ligament, ligamentum flavum, your facets, your supraspinous ligaments, all of those structures will limit how far your spine can move. In a neutral posture, there should be very minimal stretch to any of these structures. When you are in a poor posture or you are at the end of your movement, those structures can be stretched. They will be put on a stretch. So I kind of want to do I guess an experiment right now. Think of how you guys are sitting. How are you sitting right now? If you're sitting in a poor posture, probably you're sitting in lumbar lordosis. Try to sit in more lumbar lordosis. And you probably can't. You are probably already hanging out at the end of your lordosis. You are probably not using your muscle structures or any neuromuscular control to maintain that posture. You are probably relying completely on these inert structures, which at your youth and age and health, no big deal. But if you continue to have those bad postures for years and years, you're going to stretch out those inert structures, those ligaments. All those tissues will be stretched out to where you can't rely on those as easily for good positioning. All right, so that should be your cue that I want you to sit up in some kind of more neutral posture. Okay, you don't have to get to the extreme of lordosis or the extreme of kyphosis. I want you to be kind of in the middle. And when I said you were probably in lordosis, I should have said kyphosis. You're probably in a really bad lumbar posture and not lordosis. You were probably really kyphotic in the lumbar spine, or at least at the you had a reversal of your lumbar lordosis. So either way, you were probably in a really bad posture. All right, so think of what you're doing every time you sit in that bad posture. You're relying on those inert structures. You're not using your muscles. Patients do the same. That's why postural pain is so common, and that's also what we're going to talk about Monday in class. All right, active muscle restraints or muscle restraints or active restraints. There are a lot of things in your spine that can be used to help protect movement. These are the anterior structures. You have all those great stomach muscles that we talk about, your six-pack abs, you have your rectus abdominis, internal and external obliques. Posteriorly, you have lots of muscles in here. You have your psoas major, you have quadratus lumborum, you have your, what is ES? Let me see, erector spinae, sorry, multifidus, let's see, LD would be latissimus dorsi. Your transverse abdominis and internal and external obliques also come in and attach slightly posteriorly. Lots and lots of muscles that can all protect your spine, so anteriorly and posteriorly. Now what you may notice is some of these are quite far away from that spine, and some are really close to that spine, but all will help to protect your spine. So when you think of the muscles that are further away, they're more for that global stability, and the ones that are closer are more for segmental stability. If you think of, if you had blocks that were set up and you were using a guy wire here to protect it and you wanted to keep it stable, that may not be the best way to protect it. It may fall, as in here, if you don't also have some segmental stability within it. So what I'm saying is we need these external stability makers, such as those internal and external obliques, to help with global stability. But if you don't have the ability to protect each segment with things such as your multifidus, look at these, your multifidus, your even your psoas major, your quadratus, all of your erector spinae musculature, all these muscles here that can protect you segmentally, they need to be strengthened, as well as these that can protect you globally. So you need to have both global and segmental stabilization to be able to protect your spine. And so here's a list of different muscles. The global muscle function is more superficial. It's further away from the axis. It crosses multiple vertebral segments. It produces that motion and that guy wire function. And with, excuse me, it has compressive loading with strong muscle contractions. Where those deeper segmental muscle functions, they're very close to the axis of motion. They attach to each vertebral segment. Some of them may go to 2 different segments, but they do attach more locally. They control segmental motion. They also have a greater percentage of type 1 muscle fibers for endurance and not as much type 2 muscle fibers. And we talk a lot about lumbar spinal stability, and everybody talks about the multifidus and all these core stabilizing muscles, your abdominal muscles, your transverse abdominis, your erector spinae. Realize those are also present in the cervical spine, and having cervical spinal stability is also very important. So understanding the important segmental and global spinal stabilizers of the cervical spine are needed to be able to ensure that we have cervical spinal stabilization as well as lumbar spinal stabilization. And finally, that neurological control and its influence on stability. It has been noted that those who have low back pain often have altered patterns of muscle recruitment and have difficulty recruiting the transverse abdominis, internal obliques, erector spinae, and many of the other muscles that are involved in stabilizing the spine. And so being able to teach patients that feed-forward control and to be able to utilize those trunk muscles, those spinal stability muscles, are important. If they cannot, they have difficulty. That is one of those, they've lost one of the three main ways to help stabilize their spine. Also, with repetitive activity or heavy exertion of the extremities, you will get you will also have localized muscle fatigue in the spine. You'll have a greater chance of injury of the spine when you have poor spinal stability, because you'll have greater anterior and posterior shear from that limited stability. You also will notice that you'll have muscle imbalances in the flexibility and strength in the hip and shoulder and neck, and these cause asymmetrical forces that will affect your spine and posture. We're going to talk about postural faults and common postural imbalances in class on Monday. And that is it for this podcast. We'll talk about the rest of the slides in the next lecture. Thanks.